osteoporosis, fragile bone disease. Most oftentimes I give talks about total hips and total knees. And I give this talk because I really don't want to meet you guys in the emergency room or somebody who you love. Because osteoporotic fractures do have tremendous consequences. It changes people's lives. And there is a mortality rate that's higher than normal for both vertebral body fractures and femur fractures. So, very briefly, bone remodeling is dependent upon two cell types. I'm not going to get too complicated, but just a couple of simple things that everybody kind of understands where we are. Osteoblasts, they form new bone. That's these creatures over here. Osteoblasts. They form new bone. Osteoclasts is a different kind of a cell that depletes bone. So they work together. Actually, they work opposite one another. And in order for these cells to work best, you have to have calcium. Now, remodeling happens all the time. You can't stop it. It happens throughout your entire life. If you break a fracture, if you fracture your bone, remodeling is very important because in a younger person under the age of 12 or 13, it will straighten out that bone. In our age group, it won't straighten out the bone, but it will heal it. And it gets rid of the bad bone, eats it up with the osteoclast, then the new bone lays down, and you have new bone. So we need these cells, and they work all the time, and you have to have calcium for them to work optimally. Now, this is a very important sentence right here. Peak bone mass is usually achieved at the age of 30. Now, why is that important? It's important because if you have grandchildren and their children, then you need to get them to do the right thing to get their peak bone mass as high as possible, especially your granddaughters and your nieces. Those are the guys, those are the young ladies who need to get that bone built up as high as they can before they turn 30, because after that, men will lose bone at the rate of 0.3% of total bone mass per year. Women, it's almost double. That's with or without estrogen. So men, 0.3, and women, almost double. So if you don't do anything at all, you will lose a lot of bone. And a lot of women don't do anything before it's too late. Now, this is a critical slide because what happens to women is that they will lose anywhere from 3 to 6% of their bone mass after menopause because they lose the estrogen, which is necessary to preserve total bone mass. Okay? So here we are, up at 30. You can see the peak bone mass. I don't think this thing works. And then there's a little slow loss. Then you undergo menopause, and then the rapid loss occurs, and these ladies lose a lot of bone. And we are getting older. Life expectancies are getting better, so we're going to lose a lot of bone. 3% times 10 is 30%. 6% times 10 is 60%. It's cumulative every year. Okay? Now, there's a different kinds of bone loss as we get older and older. In the very early postmenopausal years, the reason why I'm talking about women is because obviously they predominate in the diagnosis of osteoporosis. It does happen in men as well. And there's one startling fact that I'll talk about a little bit later. But women, obviously, are the ones we really talk about, but it can't happen to men. Now, when you first enter menopause in the early years, 55 to 65, you lose what we call trabecular bone. Trabecular bone is the bone that is inside the hard bone. If you think about a femur, it's got the proximal end, this is the hip up here, and this is the knee down here. In between is the hard cortical bone. Okay? At the ends, that's the soft trabecular bone. In the middle is the hard cortical bone. Does that make sense? Mm-hmm. Okay? So, and in the middle, it's a lot of calcium. A lot of calcium. Towards the end of the bone, there's less calcium. So you're going to lose that trabecular bone at the ends of the bone. As you get older, you lose both the trabecular and the cortical bone. And each of those bone losses has its characteristic types of fractures. When you're younger, 55 to 65, you're going to break your wrist and your spine, have vertebral body fractures. And you get older, you break your hip and you break your shoulder. And what's really kind of unfortunate is that the hip fractures really change a woman's life. Truly change a woman's life. The next big thing that I've really become unfortunately very aware of is that when a woman breaks her shoulder, it's hell. It's pain, it's loss of motion, it's loss of function. You'll never have that shoulder will never be the same. Never be the same. And women, when they break their hip, it's a monumental phenomenon. So we don't want this to happen more than we have to. So who's at risk for osteoporosis and fractures? It's very simple. If you start off with a low peak bone mass, now fortunately, most women in this age tended to have good diets when they were growing up. Unfortunately, the young ladies today don't have the diets that the women have today, so they don't get as high a peak bone mass as most of the women in this room, okay? And at least 10 years postmenopausal, so 60, 65-ish, got a low bone mass, that's your highest risk group patient. So far, so good? Any questions? Okay. Now, there are some things that you can change about your life, and there's some things you can't change about your life. The National Osteoporosis Foundation has 4 risk factors that they have said have statistical value with the development of osteoporosis and potential fractures. These are non-modifiable, so if you're over 50 years of age and you have a fracture, that's a risk factor. That's 1. If your mother broke her hip, had a fracture, that's 2. Those you can't change. Okay? Now, modifiable risk factors are cigarette smoking and low body weight, less than 127 pounds. I know some women never get 127 pounds, but most do. So, smoking and weight. So that's the 4 risk factors you have to keep in mind when we talk about who's at risk and who needs to be treated. Okay? Cigarette smoking, weight, fracture after the age of 50, and if your mother broke your hip, or any kind of fracture whatsoever. Okay? So what exactly is osteoporosis? Osteoporosis is a silent, progressive disease. It doesn't stop. It continues to go. You can change the course of it, but you're not going to not have the change in the progressive disease. And what happens is you get decreased bone density, and unfortunately you get increased bone fragility, and with a consequent susceptibility to a fracture. So here's femoral head, femoral neck, and the femur, and you can see this really thick trabecular bone here, really small holes. And then when you get the osteoporotic bone under the microscope, you can see how you've lost a lot of that bone thickening. And now those trabecular pieces of bone become smaller and smaller. And of course, that's going to break more than that. Tensile strength or compressive forces across that is going to break that bone more likely than this bone over here. And that's what it looks like. Now, in the spine, what you see is that's nice normal bone in the vertebral body. That's a picture of a spine. And over here you can see you've lost the cross links. So the girders are missing. So now what happens is when you break this bone, you break it in compression. Okay, it doesn't fall apart, it compresses. And you break it because you don't have the support going across. And so those little pieces of thin bone right there just break. Vertebral body fracture equals pain. Pain. And then more pain. And when you're through with that, you have more pain. Now, there are some treatments, but nothing really works best if you don't ever get a vertebral body fracture. Okay. So, by definition, well, how many women in this room know their T-score? How many women? 1 hand, 2, 3. Wow. How many people in this room know their T-score? How many people in this room know their T-score?
Bone density. They don't know what it is.
Well, if you don't know what it is,
then
you probably know what your T-score is. You see what? Now, this is an unusual group, I gotta admit. If I give the same talk in other cities, like no hands go up. So I'm really delighted that a lot of hands go up. But a T-score is how we make the diagnosis from an objective standpoint. So a T-score less than -2.5, so -2.5, -2.6, that's osteoporosis.
What's the test to reach the score?
Coming right up. Okay, got it? That's an important number to remember. Minus 2.5. Okay? We'll talk about that a little bit later because it really is important. In the United States, 10 million people have osteoporosis. Now you know what that is. Now you have osteopenia. People say you have osteopenia. That's a T-score of minus 2.5 to minus 1.0. That's osteopenia. Probably the majority of the women in this room are at least osteopenic. Well, maybe not you. Not you either. But most women in this room are probably osteopenic. Okay?
Question?
Sir?
Doctor, osteopenia, well, isn't one less than 2.5?
Minus 2.6 would be less than minus 2.5. That's, this minus sign goes in front of that.
Well, that's a plus sign?
That's a minus.
This is a minus sign. But that's a good number when you, no, yeah, this minus goes over here in front of this one. I messed this slide up. It's not a plus one. If you're a plus one, you have superhuman bone in this age group. Okay, we're going to go over this in just 1 second. That might even be the next slide. That is confusing. Thank you. So, what happens with osteoporotic fractures? This is the most dreaded one of the 1.5 million fractures. About 300,000 in fractures a year. Spine fractures, 700,000. Vertebral body fractures are very common. Very, very common. Some of them may not be quite so painful, but across the board, spine fractures, vertebral body fractures are painful. The other fractures include the shoulder in the older patient, and about 250,000 wrist fractures. Wrist fractures, I'm going to go a little bit of the treatment later on, so I won't talk about that right now. But I'm not going to go into big expansion, but just tell you where we've gone in the last 20 years. So you can see there's a lot of fractures, 1.5 million fractures. Let's talk about these. Up to half of women over 50 will break a bone due to osteoporosis in their lifetime. That's a pretty startling statistic. Approximately 2 osteoporotic fractures occur in women every minute in the United States. So it's not uncommon. In fact, it's quite common. Okay. Well, let's do this. Hip fractures in women. Lifetime risk of hip fracture is greater than the risk of breast, endometrial, and ovarian cancer combined. So it's common. It's common. I think I pull call here in this hospital 6 nights a month. And I would probably say on 2 of those nights, I have to take care of at least 1 hip fracture. And I would say pretty much every time I'm on call, I will take care of some type of osteoporotic fracture. Now, I've got to admit this neighborhood is a little bit different than some other places, but osteoporotic fractures are very common. Now, vertebral body fractures in particular. Remember, women will lose up to 1/3 of their spinal bone mass in the first 6 years after menopause, so that's when you're going to be susceptible. Okay? Women with a clinically diagnosed vertebral body have a 70% chance of another one in 10 years. And then this is what happens. If you get 3 to 5 vertebral body fractures, then there's a markedly increased mortality rate. So the mortality rate for the vertebral body hasn't been absolutely determined, but if you get 3 to 5 of them, that's almost intuitive, because if you have 3 to 5 vertebral body fractures, something else is going to break. There's something that's wrong that you have that many vertebral body fractures. Okay? So that changes the mortality rate. And I'll be quite honest with you, if you don't think about, if there's no other way to think about it this way. If somebody has 3 to 5 vertebral body fractures, they're probably not very healthy. Probably going to be spending a lot of time in bed, and then the systems just keep moving in the wrong direction. Because these typically are very, very painful. Even if you have kyphoplasty, where we inject cement in them, they still cause pain. Okay? Hip fractures. This is the second number I want you to remember. 50% of all victims of a hip fracture will be disabled. I say victims, it's kind of an odd word, but when you see these women after their hip fractures, they're never the same. And one thing that never changes is the attitude that they have. They'll always, it must be very painful because they don't want to fall again. They won't let go of their walker, they won't let go of their cane. They're not, most of them do not achieve the prior level of function. In fact, 25% of them require long-term nursing home care. Because remember, these are not 55-year-old healthy women. These are not 60. These are 70 and 75. 2 months ago, I took care of 3 fractures in 3 women who were between the 80 and 85. First one had a stroke, second one had a heart attack and died, and I think the third one just gave up within a month. And we don't know, I don't know why it happened. It's just, we haven't changed that over the course of time. And this number right here hasn't changed at all. 24% of women will die within a year. Personally, I think what it is that at least the generation that I'm the bottom part of, and that's, I think these folks really become really attached to one another. They have really true marriages, and I think that they really have a lot of affection and love for one another. And when one leaves, they break their hip, they say, what the heck, you know, I'm not gonna have that good a life, I'm out of here, and they leave. Contrarily, if I see an older woman who has a really nice family, really supportive, still has a spouse, you could almost predict that that person is probably going to do okay. I mean, it changed their lives, the way they do business, it becomes more dependent on the family, but it's that woman who comes from the nursing home, that's almost a kiss of death. They're usually don't hang around that long. It's the ones that have some support that seem to do fairly well. And I've been practicing orthopedic for decades, and that hasn't changed at all. Despite the fact that we have much better techniques and we try to do better, but it just doesn't change that number. Sir?
I mean, can we put them on, you know, oxycodone or Percocet or something? To improve their life instead of being in pain and dying.
Well, you know what, the problem with that is that I don't mind using narcotics, and I do remember when my father-in-law died, one thing I learned was that dying is painful. And so they'll give them the morphine as they continue to go on. But the problem with using narcotics in older patients, like one of my patients, my total hip patients, is that they can't cooperate. They just lose it. You know, their mentation doesn't work, and they get constipated, and it's very, very difficult. As a matter of fact, it's quite the contrary. You know, they don't want the narcotics most of the time, and I really don't use narcotics. Typically, in patients who are 78, 80 years old, I use very, very few narcotics. I don't use any IV narcotics in that age group at all, even after a total hip or a total knee. And people in this community, it's not uncommon to do a total knee or a total hip on an 80-year-old patient. I mean, it's really not uncommon.
Are they still able to do physical therapy? I mean, because that's supposed to really help you and help your attitude, and see you do physical therapy for an 80-year-old?
I think what happens, madam, I think what happens is they just basically give up. I think they just said, you know, it's just too much. And I'll show you some of the things that we do for hip fractures. It takes me to fix a hip fracture, it takes me 30 minutes. I can have you on and off the table in 30 minutes. I can do it within 24 hours. I can give you zolinic acid. I do everything I can to make it better, but it just doesn't seem to change the mortality rate. And I truly think in my mind, in my little pea brain, it's how their social environment is before they got into the hospital.
Or is it in their attitude? I mean, because you've got some positive 80-year-olds that...
Absolutely. If an 80-year-old comes in and they got a granddaughter who's, you know, dawdling, and they got a husband, they do fine.
Okay.
They do fine. It's those poor ladies who don't have a lot of support. They just check out. So, who's a candidate for testing for osteoporosis? Who needs to get a bone mineral density study? Anybody who's 65 years old, regardless of additional risk factors. Those who are postmenopausal, under the age of 65, who have one of those 4 additional risk factors. Postmenopausal women who present with a fracture, any kind of fracture. If you break your wrist, you break your shoulder, you break anything, you vertebral body fracture, you should probably get a bone density study. People who have been on estrogen therapy for prolonged periods, because this estrogen isn't protecting you. The normal process is happening, and you're losing your 0.5% bone a year. So you think you're protected, but you're really not. Okay. Estrogen is not a form of treatment for osteoporosis. That's been going for a long time. The OBGYN guys think it is, but it really isn't. And gross. So, how do we check this? You can get a dual energy X-ray, optometry, or a DEXA scan, or you can do it peripherally. This is what they look like. This is the bone density study. The most important thing on this slide is wherever you get your first bone density study, that's where you get your second and your third and your fourth. Because the tolerance of the measurement, the variation is so small that if you go to different machines, they're calibrated differently. So you cannot compare one machine measurement to another, okay? This is my preferred, this is the femur, this is the hip, that's femoral neck. That's the number you should concentrate on. I want you to know your T-score at your femoral neck region. That's the most important one. Not the wrist, not the shoulder, not the forearm, the wrist. Now, this picture over here on top, everybody can recognize that as the spine.
Yes.
Now, people come in and they say, well, I don't have osteoporosis. My T-score at my spine is +1. So I say, okay, well, let's go get some x-rays of your back. And I can guarantee you that you have arthritis in your back. Because that DEXA scan just looks at bone, doesn't differentiate between good bone and bad bone. So a lot of folks who are over 60 will have the positive calcium or osteophytes or extra bone because of the arthritis in their spine. And that bone density study, that plus number or the -0.5, they're so happy, but that's not a good number because too often it's falsely elevated because of the arthritis. You don't think that doesn't make sense to you?
Oh, it does.
Okay, good.
I'm just checking out, I'm sorry.
Yes, ma'am.
Question. Okay, what if you had both hips replaced? Would
Then-
you put that a DEXA
Then I think what you
scan?
got to do is you either go to the wrist, or if you don't have, when you come to me, I'm going to take a look at this, and I'm going to see what your bone density is in your spine, your lumbar spine. Take your lowest one, I get an x-ray of your back, make sure there's no extra bone from the osteoarthritis or have the arthritis in the spine. If it's a clean, then that's a good number. Then that's the one I would use. But yeah, you got it. The hip is the best one. Yes, sir.
So far, your discussion is centered on women and osteoporosis. Don't men have to worry, or do you intend to discuss that later?
Men do have to worry. I bypassed something that I should probably go back in. Now, the mortality rate for a year for a woman is 24%. The mortality rate for a man is 44%. Yep. Now, I will see probably, I don't know, if I had to guess, maybe 100 to 1. I think in the last 5 years that I've done hip fractures here at Centero, I probably have done just a handful of men. And I will tell you one thing. I would say probably 97% are white women. I rarely see a black woman with osteoporosis. Rarely. I just don't see it. And that's the case too, across the country. Black women do not get osteoporosis. Okay. Now, with regards to men and their development of osteoporosis, they'll probably most likely get osteoporosis because they're being treated for cancer, and a lot of the cancer drugs absorb bone, and then they get into trouble, and they have to take something called Forteo or some other. There's a lot of new drugs out there that help you replace the bone, so it wasn't as bad as before. And then their hormone, the parathyroid disease also can cause problems with men and osteoporosis. Osteoporotic men, their diet are different than females, and I can talk about that in a second. But men don't have to worry about it as much. But if you have a fracture and you're worried about it, then you can get a bone density study. Now, here's the problem. If I haven't talked much about it tonight, the National Osteoporosis Foundation says that if we're going to use your T-score, we have to compare it to women, because there is no cohort study for men. So I don't have that either, which is unfortunate because that's not fair, because we know they're not the same. T-score. Yes, sir.
So basically, you're saying it's part of our
just use another example. Eskimos. Eskimos have the highest rate of osteoporosis because of their ingestion of protein. They have good calcium levels, but their protein levels are very high, higher than most people in the lower 48. But so that, and we think that there's a correlation between that very high protein consumption and the absorption of calcium and the subsequent formation of osteoporosis. But I don't think you can say that about a black woman. And we all know that if you're fair skinned, blonde, and blue eyed, you're probably high probability you're going to get osteoporosis. It's almost, that is the group of women who get it. Thank you, ma'am. Those are the ones who get it.
Oh, so there's a few here.
I know. Are they on?
I can't hear it from here.
Michelle? Am I on?
They ended it, sorry.
Okay. All right, so a T-score. It's based on a bone mineral density of 30 to a 35-year-old. That's 0. That's why most women cannot have a T-score in a positive range, because 0 is a 30 to 35-year-old woman. The T-score just measures the patient's bone mineral density compared to this young female. The T-score is just a standard deviation. It's not in milligrams or, there's no other, the unit of measurement is a standard deviation. And then the T-score for most patients is a negative number because it's less than the bone mineral density of the 30 to 35-year-old Christian man. Does that make sense?
What?
Yes. You were looking at the board, I was thinking, Does it make sense? Yeah. So, if you're 30 to 35, your T-score is probably going to be 0. As you get older, 50, 55, it's not going to be 0. It's going to be minus something. It's going to be a minus number. Very common. It's a positive. The positive number is probably have a hormonal disease or you have bad osteoarthritis and you lay down that normal bone. So here we go. This is exactly what it is. Normal bone, because for the age, minus 1.0, can't be 0. Osteopenia, or thin bone, minus 1.0 to minus 2.49. And then again, osteoporosis is below minus 2.5. Okay? This is the number you need to remember.
What's the highest bone?
Well, if you're 0, you can go positive, but...
No, but what's the worst?
Oh, I had a lady who came in out today, she was minus 4.5. Yeah, she needs something real bad, but she won't be treated.
She won't be treated?
No, I'm tired of taking care of her. Because I'm gonna fix both of her hips and fix her shoulder, you gotta take, after all of that, you would have thought that she would take Forteo, because
there's things you could do.
Calcium and change her protein level and take a little bit of magnesium and fix things. But she's convinced that she doesn't need to be treated.
Is that Forteo that you're talking about, is that right? How do you spell that?
I'll show you.
Oh, okay, perfect.
Okay. Any questions? Yes, ma'am.
Some of those drugs, like Prolia or shots, they have such terrible side effects that women are often afraid to take them.
That's right. So when I get to this next section on treatment, that's why we have to have a serious discussion. Okay? All right. So just for an example, if you have a minus 2.0, that means that you're 20% below normal. Okay? So that's a lot of bone. That's a lot of bone. Now, T-score is important to know because it's a very strong predictor of fracture risk. Obviously, the higher you lower your T-score, minus 2.5, minus 4, et cetera, it's a good predictor of fracture. In fact, it's better than cholesterol is for coronary heart disease. So you should know that. You should know this, man.
When you say fracture, you're not just a fracture in the bone, you mean a complete break? What's the difference?
Fracture in my mind, both of those constitute in my mind a fracture.
Okay.
Both of those are fractures. So if you have osteopenic bone, and most people in this room have osteopenic bone, then you have a double increase of fracture risk. And if you have osteoporotic bone, you have 4 times the chance of breaking something. the normal population. Okay? So it's really, really, really good idea to know your T-score. I would call your physician and say, what is my T-score? I said, I got 4 risk factors. So what's my probability of fracturing? Well, now, within the last 5 or 6 years, there's this developed frax tool, and it is a diagnostic tool that you can get somebody to estimate your 10-year probability of a fracture. And it's a hip or a major osteoporotic fracture. It's like they get, a stress test and say, well, you get a stress test, you have like a 2% of getting a heart attack in the next 10 years. That's what this does for women. It's not very popular, you gotta ask for it, but it's definitely available. Frax tool, okay? It's based on individuals' clinical risk factors and the bone mineral density of the femoral neck. Okay? All right. And what we do know is that all high-risk patients have a T-score in the osteoporotic range. Did you check me in?
Yeah.
Okay, good. All right. So this is new. Not many people know about it. So if you want to say, what's my probability of breaking my hip? Oh, doctor, blood marker. What's my frax? And you give them all the numbers. They should have all the data from your chart, and they'll give you a number. Okay. That's kind of a nice thing. So who should be treated? Okay, this is the meat of the whole thing. This is probably what most people want to know. You have a T-score less than minus 1.5 with risk factors, you should be treated. T-score a minus 2.4, a minus 2.0 with no risk factors, you should be treated. Now what I typically see is somebody with a T-score minus 2.0 and a broken hip, or a broken shoulder, or a broken wrist, or a broken ankle, broken something. This is my most common population. Postmenopausal women with a fracture. They need to be treated. Okay? Because there's some reason why they broke. We know that you have osteopenia. You got to at least have osteopenia and probably osteoporotic. So you need to be treated. Well, how do you treat this? Calcium citrate. Best absorbed supplemental source of calcium. It can be taken on an empty stomach. I like citric acid. Okay? Do not take calcium gluconate or lactate because it has oyster shell, and that should be avoided because it has iodine and other junk in it. So calcium gluconate and lactate is from oyster shell, so don't do that. You can't take calcium carbonate, it's the most common, cheap, but you gotta take it with meals. But this is the best absorbed. So if you want to absorb, yes sir.
I've heard there's a certain age it does no good to take that. Is that true?
No, that's not true.
So as long as you live.
I do think that's a cheap way. It's a cheap way because by the time as you get older, and now it becomes more of a hormonal thing, and your digestive tract. They don't work. They don't absorb as much as we used to. So you got to take a little more calcium. But calcium can always be used in the body. Can always be used in the body because you're losing calcium all the time. And as you get older and you lose more and more bone, you have less. Now you may run out of calcium. You're not going to run out of calcium, but your bone stores are going to be less and less as you get older.
Except if you have kidney stones, and I've run into that because I can't do a lot of extra calcium even though I do the citrate. And a doctor, that's it, you know?
I hear that from time to time, and I don't have a good argument for that. I still think you probably should take the lower level, maybe like closer to 800 and 900, maybe 1,000 milligrams of calcium, but I do think you need to take calcium.
Yeah, I do 1,200.
Take 1,200.
The calcium citrate, but
Okay.
then I developed kidney stones again, so.
Well, yeah, those are painful, I hear.
18 of them, yeah.
Oh my God.
So can you take calcium at all?
I'm not supposed to, but I am, because of the bone issue.
Okay. What's your T-score?
I'm not sure, it's not good.
Oh, okay. Yes, sir.
When you mentioned calcium, what about calcium from milk and yogurt?
Oh, okay, now, I didn't put the number up here, but I think it's the next one. Let me, that's magnesium. The recommended dose is 12 to 1,500, but that's supplemental. So if you're taking milk, if you drink a lot of milk, take a lot of dairy products, then you just have to supplement. So whatever, you just add that to get to 12 to 1,500. And that's even probably better. That's a very good point that you should, these are supplemental values, okay? Some people that's all they do is they just take calcium. Now that may get people in trouble. If you take a lot of dairy products and then you take a lot of calcium, then yeah, you can be over the top. But if you're working with something must be wrong with your nephrons, and I think people who have a little kidney problems is a little bit of an issue, but that's supplemental, okay? So you don't go and take like 10 times. Magnesium, controversial. But we do know that magnesium is involved in bone formation and influences the activities of the osteoblasts and the osteoclasts. We do know that there's a positive association between magnesium and bone mineral density. If you have good magnesium, you probably are going to have a better bone mineral density. Osteoporotic women have low magnesium levels. Okay? Why are we talking about magnesium? Because of this one right here. It's very important in bone formation. So, if you're 14 to 18, you need 360 milligrams, bless you. And as you get older, bless you, then you need, most people in this group, 320 milligrams of magnesium. Green leafy vegetables, spinach, almonds have a very good source of magnesium. Easy? Okay. Protein. Controversy. This is a controversial point. Studies have shown that high protein diets result in bone resorption and increased urinary calcium. On the other hand, people say high protein diets are actually associated with greater bone mass and fewer fractures when calcium intake is adequate. Plant proteins are more beneficial than animal proteins. So the story is, eat your peas and take your calcium. That's the message, okay? Yes, sir.
What about eggs?
Eggs are good. Eggs are going to be, I don't know if you consider those are probably animal protein, I would think.
No, it's a chicken and egg question.
Well, I gotta tell you one thing. I do know that for magnesium, you got the chlorophyll in these proteins is good. So greeny leaves are good. Now, I never knew that there was such thing as plant protein, but they tell me there is. Peas, that's why I put peas, because I did find that peas have protein in it. I know soybean does, and some beans do, yeah. So the ladies know what they know what it is. You know. The guys may not, but the ladies know. So eat your peas and take your calcium. So, in some cases, well, all the medicines used to treat osteoporosis act through different methods, and we don't want to be all night on that. We're not going to be biochemists or pharmacists to decrease the rate of bone loss. That's typically what they do, is they slow down bone loss. There's one that actually adds bone to bone, but fundamentally, if you're talking about being treated for osteoporosis, you're slowing down the bone loss. You cannot stop it. Now, from density study to density study, even if your bone mineral density, if your T-score does not go down, that's a victory. Okay? It doesn't have to go up. It just has to stay the same. That's a victory. Because you have a natural loss, and you're going straight across. So you're not getting that natural loss that you see in females. So you don't have to go from a minus 2.5 to a minus 2 to a minus 1. That ain't going to happen. You just don't want to get any lower. Okay? That's a victory. Just stay even. So, decreased bone allows the rate of bone formation, blah, blah, blah. Treat destruction of overall bony architecture. 12 to 1,500 milligrams. Those are two more numbers you should probably put on your piece of paper. 12 to 1,500 milligrams of calcium, 1,000 international units of vitamin D. This number may be coming down based on current studies, but that's a good number. 12 to 15 and 1,000. And then this warning right here. Estrogen or hormone replacement therapy no longer is used for treatment of osteoporosis. Okay? Right.
Can I ask one other question? What about that vitamin D? Someone recommended to me the shot they're giving twice a year. If you're really low in that vitamin D,
I think you need to have your 125 vitamin D measured, and if it's low, it needs to be brought back up into a normal level. So there are people who do recommend, IV 6 centers.
every 6 months, they said that for people that can't absorb that vitamin D as well?
That's true. And that happens as we get a little bit older. Now, the more the bone mineral density is increased, the lower the risk of fracture. So here we see Fosamax, the dreaded Fosamax, the drug that everybody loves to hate, which Dr. Cavazos loves. Prolia, but just look at this. I mean, look at femoral neck. Look at lumbar spine. What it does to bone mineral density. It's just such a great medicine. Here is the one that the OBGYN guys like,
Oh,
Boniva. Boniva is a waste of your time and money. Actinol, that's in the same category as glucosamine, chondroitin sulfate. Take it if you want, but it ain't gonna do you anything. Now this is an interesting, this is way down here, but these two medicines right here, and I'll talk about it in a second. But overall, ladies and gentlemen, Fosamax has demonstrated the best overall medicine to increase bone mineral density in postmenopausal women. Okay? Of that class of medicine. Okay? Now, the more a drug reduces the risk of fracture, the better it performs in the treatment of osteoporosis. So here's Forteo, way up here. But most of you guys are never going to go in Forteo. So, you should go on Fosamax. It's a very, very, very good medicine. Zometa, you're not going to go on that either. Prolia is a very, very good one. And then you got 000. These are the OBGYN medicines. Okay? Boniva, Evista, Actinol, 0.0. Okay? Nothing in the femoral neck. Don't do anything in the femoral neck. They can do something in the vertebral bodies, but these bad boys right here, that's what you want to decrease the most. Okay? Can you get copies of these slides?
Yes.
Okay. So, Forteo. It's a fragment of parathyroid hormone that regulates the metabolism of bone. It's daily injections for weeks. High-risk patients for fractures. If you have a T-score of -4, -4.5, Forteo is your man. That's what you need to take. Most of you cats in here are not going to need Forteo. The reason why it's not very well liked is because in rats it's shown to have caused osteosarcoma. It's not reported in humans, but it's enough to scare most people off. Okay.
Say that again. What about what was the drawback?
what is that?
Osteosarcoma is bone cancer.
Oh, okay.
Bone cancer.
Bone cancer.
Yeah.
Wow.
Yeah, not good. Not good. Okay. And why would it cause osteosarcoma? Well, I'll show you slides at the very, very, very end. But it is the only medicine that will clearly make your T-score skyrocket. Because it will add bone. It is amazing how much bone you can add on. But most of you cats in here don't need it. If your T-score is -4.40, then you -5, -3, then you should probably consider this because it will get you out of the danger zone. Okay? Zometa, very, very nice medicine, but again, it's very convenient. Single annual infusion decreases vertebral body fractures by 70 and hip by 41, but nobody wants to be messing with their heart. Okay? Great. So nobody wants atrial fibrillation. That's a pain in the ass. But it's a great medicine. But, atrial fibrillation. Too bad. We got good medicine for that, but you just don't want to take it. But if you need it, because you're talking about decreasing mortality, okay, we can decrease mortality after a hip fracture if we give you a shot of Zometa after you break your hip within 90 days, but nobody does it. In fact, I think that study was done up at UVA actually, but nobody does it. And quite honestly, I gotta admit, I don't do it either. But that study's been done. One single, how convenient is that, right? Too bad. Right. So, Prolia, my favorite drug. I'm not going to go through all of this up here, but it does inhibit the development of osteoclasts, bone-eating cells, right? Decreases the vertebral body, decreases hip fracture, another fracture by 20% every 6 months. It's a small, tiny needle. It's very convenient. I'm pretty sure most, if not all, insurances cover it. Yes, ma'am.
Do you take it for the rest of your life then, or is it at like 5 years?
5 years? You've been doing a lot of reading. Prolia has, I think maybe in the last year, has had 1, maybe 2 spontaneous hip fractures. So why do people go on vacation or go on a holiday or not take it after 5 years? It's because of the spontaneous hip fractures. I'll talk about in a second. Maybe. Oh, here it is right here. Okay. So if you take zoledronic acid, decreases mortality by 28%. Nobody does that, unfortunately, if you give it with 9 days of injury. Bisphosphonates have been shown to be related to spontaneous subtrochanteric fractures of the femur. That's what you're talking about. So I think the next slide is, okay, spontaneous atypical femur fractures. Why do these happen?
Yeah.
Katie Couric, God bless her, brought somebody on and talked about the fact that their practice has seen these spontaneous femur fractures. Scared the hell out of everybody, and then everybody adjusted their treatment protocols and attitudes towards Fosamax. But Dr. Black in the New England Journal of Medicine in May of 2010 saw 12 fractures in 10 patients, identified 284 patients, and 14,195 for a rate of 2.3 per 10,000 patients. He says, they're rare. They're rare, and they are rare. Quite honestly, I've never seen one. I never have. But they happen. I mean, there's no doubt about that. So the question to you, madam, is do you take a drug holiday or you discontinue? Now, what most people don't know, as she knows, I didn't have a slide up there on Fosamax.
No.
Because nobody wants to take it.
Why?
Because of this. Because of that. Now, although I do think that the New England Journal of Medicine is probably one of the most reputable medical journals in the country. And Dr. Black, that's one article. He's written several other articles that say that it's a rare phenomenon. Now, because of that, most people would say you're going to go on Fosamax, you take it for 5 years, and then you take a holiday, and you can come back. What most people don't know is that if you take Fosamax, there's a continued benefit after you stop the medicine for maybe up to another 5 years. Okay? So you can stop it for 5 years, probably resume it again, and do okay. But people don't like it, but it's been demonized, if you will. But it's a great drug. It's a great, great drug. Does anybody take this, sir?
I assume that all these drug treatments you're talking about should be based upon strictly doctor's advice and not undertaken by individuals themselves.
Yeah, they're all prescribed. I think it gets confusing because there was I would say 3 or 4 years ago, there's a big push for Forteo. And I mean, the likelihood of you getting osteosarcoma is probably next to zero. But if you got to tell everybody that you could get osteosarcoma, I mean, hell, you don't want to tell people you're going to get cancer because you're taking a drug. I mean, you just don't want to do that. It really, makes it not want to be taken. And some people have to. Again, I go back to Fosamax. It's a great drug. It really is. It works very, very well. And if you stop at 5 years, there's probably no untoward effects. True, because it does the side effects. The other side effects from Fosamax is you can get osteoporosis of the jaw. Rare. Prolia doesn't have all of those. You can get you get a skin rash. Prolia is very safe. I guess now, if I had to choose on a multiple choice question, Prolia would be my drug of choice. There's not a lot of, how would you say, allergic reactions. I've never heard anybody that's not a common complaint with it. Again, there's these skin rashes, the skin infections you can get, but it doesn't have anything else. And it's very convenient, and it just takes a shot, and it's very effective. If you remember looking at those slides. And if you want to copy these slides and all numbers, you can have that, you can get those. But Prolia is just, it's the way to go, it's easy. Because the Fosamax, what do you got to do? You got to get up in the morning, you got to wait 30 minutes, take it with water, you can't lie back down again, blah, 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 you get esophagitis, the thing sits there, so, yeah, it's a bummer to take it, but when you take it, it's good. And for a while, that's all we had, and it was the best, because the OBGYN drugs don't do a damn thing for you. And so, an estrogen, you can't take estrogen because it's not going to solve the problem. Okay? You don't, because you're going to continue that downward trend of bone loss. Then you're going to see me in the emergency room. Then you're going to have to operate. Sir?
To encourage awareness, your target audience, postmenopausal women.
Yes, sir.
Should their primary physician put that in as a protocol on an annual? Should they get a DEXA?
Oh my God, absolutely positively. I mean, oh my God, it's just like, nobody in this room should walk out of here without knowing their T-score. Nobody. Everybody in this room knows their damn blood pressure. I know their cholesterol level, but you don't know your T-score. And it's more important than your damn cholesterol level. Excuse my French, but I mean, let me tell you, it is sad they get called in And if I have to see a woman with a broken shoulder, I gotta tell her, man, it's never gonna be the same. Never gonna be the same. Yes, sir.
I notice that most medical points today here are 20 minutes long for the doctor.
Well, you're lucky.
I find that you can only discuss, have time to discuss one problem, and no doctor, in my experience, has addressed the whole picture. Should I go to Johns Hopkins or some clinic that can give a whole body approach to determine the directions that should go in solving the potential problems and real problems of that?
And you know, I couldn't agree with you more. I could not agree with you more. I mean, I just like osteoporosis. I mean, I love osteoporosis. I love the disease. I love talking about it because I just don't, I mean, even if you come in, I remember when I first started practice, we used to put 2 pins here and 2 pins here for just a radius fracture. Then you take the external fixator off 6 weeks later, and then you got a stiff hand. Can't do anything with it. Can't comb your hair. You can't get dressed. It was ridiculous. And then the trend came, well, you know, I'll get to that, but I mean, the treatments we had back then were horrible. They're only better, but those 2 factors, 44%, 24%, have not changed. My practice always since 1990. It has not changed at all. You know, and God is my witness. Every time I'm on call, somebody broke something. A woman comes in for something. Pretty much every time then my partners are just as bad. I mean, they see just as much as I do.
Can't you have different T-scores? Like, I had an MRI done, like it says, you know, a
MRI or
minus,
DEXA scan?
a scan.
Okay.
But if you have that done, it says like a minus here and say your neck, and then it's your hip might be worse there. So you have a different score.
Correct.
In those. So where would you get your T-score?
Yep.
Always in the hip, like you said.
Yep.
Even though the other area might be
Don't
worse.
discount those. If you don't have this, I guess somebody has bilateral hip replacement. They have bilateral hip replacement, you obviously can't do the hip. But the hip, that femoral neck, you want the femoral neck number. The worst of those 2 is your T-score. That's what you have to remember. Okay? Yes, sir.
Who has the DEXA equipment?
Who has it?
Women's Imaging Center.
Women's Imaging Center.
Women's Imaging Center.
Yeah.
Okay.
And they should calibrate. Ask them when you go in there, do you calibrate this machine every day? If they don't get your T-score there. Don't get this again. They got to calibrate it every day.
Every day.
Every day?
What did I say?
Every day.
Thank you.
Really? Do you think they do it every day?
We call before we have a report.
So what I'm hearing you say is, that I was on phosphate for 8 years, and then the alarm bells went off, and he said, stop it. So I haven't taken it now for almost 3 years. What
You're
I'm
still
hearing you
good.
say, yeah, but I would eventually go back on it, is your recommendation.
Either that, if you took it and you didn't have any side effects, it's not a bad idea. If you want to switch over to Prolia, you could do that too. It's easier, I don't know if it's any cheaper, and now you can take it like weekly with the Fosamax. You can take it every day.
Oh,
That's
really?
painful. Women never did that. I don't do that, I mean, for Christ's sakes. So, let's skip this one and go to this one. This is my favorite operation. Direct anterior total hip. Love it, okay? But I don't want to do it in hip fractures. I want to do it if you have bad arthritis. So what we do is we approach the hip fracture without cutting any muscle, tendon, or ligament. Okay, it's a direct anterior. And here's the incision right here. So in real life, that incision is that long. Okay, I can do a total hip incision that long. And it's the most rapid recovery possible with a total hip arthroplasty or a bipolar. So to put in, this is probably the most common thing I do. If you're 75 or 80, you're going to get this if you break your femoral neck. If you're 65 and you come in, you're going to get a hip replacement. So you're going to get this, a titanium cup with a very high density polyethylene plastic with a nice pink ceramic ball, and then another piece of titanium. Okay? We do these all the time. Now, before, say 10 years ago, you come in, women get this, and they hang around in bed for 5 or 6 days, okay? Because, you know, I gotta get past the pain, blah, 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 you have hip precautions, you can't sit over, you can't lean over, you can't do this. But you go to the front, there's no hip precautions. You can get up, go get a shower, sit on the toilet, walk, go home, okay? So that's been really a good thing that we've done. So this direct anterior approach, and we've been doing it now for 13 years, and I do all my hips except for major revisions. I can revise the cup part through the anterior approach, but if I have to take out the stem, then I gotta go to the side because it's just too hard to turn the angle. But direct anterior approach, me and Ed, is the way to go. People disagree with me, but this poor cat over here, she broke her femoral neck, could be a ye, but this is the fracture right here, right there. And so what we do is we put in the bipolar, and that's what it looks like. Okay, 35 minutes on a slow day. You do a few and you can't figure it out. Okay, so that's a femoral neck fracture. That's bipolar implant. Almost those need this because when you break right here, the blood vessels into the head or through the neck. So when you break your femoral neck, the blood supply to the head is going to die. So you got to take it out and just do something with it. So that's why we have to replace it with an implant, 100% of the time. Some folks, I don't know why they do it anymore, but they still do it. Some people will pull on this and make that head go up like that, and they'll put 3 pins in it, and then they come and see me so I can revise it. So, I don't know why people do that, because that bone is osteoporotic by definition. So why you would put 3 pins in it doesn't make any sense to me. But we see a fair number of those. Okay, so this is, everybody can see this. That's broken off, that's broken off, that's broken off, and that's broken off. And then what you do is you kind of line it all up and you put this rod down. 35 minutes.
Wow.
Okay. This we don't put back on either, so if I go back and get that, I'll probably bag a nerve, so we leave that alone. So this is really a very, but unfortunately you can't weight bear with this. You can't walk on that. On that total hip, the way you do that bipolar, you can walk on that. You can shower, you can do whatever you want.
So they do this because you can't do the other.
Well, with this one, the fracture line is down here. So this neck, you see it's not broken. So you capture this piece with this screw, and then this screw goes to this rod, which is in the middle of the femur, and you put one screw across to lock everything so it loses one piece. Okay? So this is an intramedullary nail. You can't weight bear for like a while.
Wow.
Because what happens, if you put this nail a little bit too high, then or you put it too deep, you cause arthritis, and I got to revise you to a total hip. And if this put it too high up, it'll cut out because this is osteoporotic bone. It's bad bone.
Why
Yes.
don't you just do a total hip, may I ask?
On this I can't.
You can't.
No, I can't because I got this piece, this piece, this piece, and this piece. Too many pieces.
Too many pieces.
Yeah, it's it won't work. The femoral neck, the other one you saw before,
Yeah,
that's just one piece. The fracture's right there.
I got
You can see this is all the fracture's right
you.
there.
Yeah. But with the 4 pieces of the blood vessels, that's not going to work either.
Yeah, because, no, you're worried about the head,
Yeah.
you're worried about this, but you can see that neck is intact.
Oh.
So the vessels that are going to the head are good. Okay, so you do that with the iron nail. Okay? So stability tendon and major implant, that's a very common hip fracture. We do a ton of those. Now, the reverse total shoulder, does everybody know what that is?
Yeah.
Okay, so this is the new standard treatment for an osteoporotic hip fracture. Shoulder fracture. Now, when you do this operation, you don't replace the rotator cuff. So that means that you cannot lift anything more than 5 pounds. That's it. 5 pounds.
Ever?
Ever.
Ever.
Ever. Could be a year, could be 20 years.
Until you check out.
And coming over here, trying to get something off the shelf, bring it down, ain't happening. Okay? Not gonna work. But what you do, you only have one muscle moving your shoulder, for the most part. That's the deltoid muscle. You have the deltoid muscle. Now, if you break your shoulder and bag your axillary nerve, you're crippled. That shoulder's gone. Forget it. Because you've got to have an axillary nerve to fire that deltoid to move that implant. So, if you have a regular shoulder, Then you have the ball down here, like it's supposed to be, and the cup over here. But with a reverse total shoulder, the ball goes over here on the shoulder, and the cup goes on the humerus. So they're reversed. Okay? So this ball is rotating like this inside the cup, and this one right here, that cup is rotating on the ball. It's different mechanical. Okay? That's why that one works. But if you don't have a deltoid, or so you go in there, you're not going to move it, you're frozen. That's it. There's no redemption with this. If you do this, that's it. That's into the road. Nothing else you can do. If that gets infected, not good. Don't break your shoulder. It's not a good idea. Those women are so unhappy, it's unbelievable. They're very, very unhappy. Try to come in and cheer them up, but it's like, okay. It's just very difficult. All right, so don't break a shoulder. Okay?
Okay.
Eat your beat and take your counseling. Now this is a wrist fracture. Everybody can see that over there. It's a fairly routine kind of wrist fracture. And then we put a plate on it. If you go through the bottom of the wrist, takes, again, about 30 minutes. And we put this plate in. You got 4 screws in this piece here and then a couple screws down here. Now, the good thing about this is really very good. Because we just put a little plate on there for like 10 days, and then you're good to go. That's it. You move it, you do whatever you want, and you get your range of motion back. Don't let anybody put you in a cast, because you're going to get stiff, because you got to go into a long arm cast first, because you got to block this so you can't do this. So you have to go above the elbow for 4 weeks, 3 weeks, then you go to short arm cast, and blah, 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 and another 3 weeks. Now you can't move your wrist. Now you're really upset because you can't do anything. Your clothes on. It's painful. It's painful. So just go ahead and put this plate on it, up for the plate function, plate operation, fix that thing, and move rapidly. Rapidly.
How rapid?
You move it like in 5 days. Yeah, do it very well. Okay? So this is new ideas. New ideas. You still find some cats out there that want to put pins in it, want to put you in a cast. Go to somebody who's going to play you. Seriously. Really seriously. And the rate of infection in this thing is very, very, very low. Complication rate from this is very, very, very low. Okay, so as long as these screws aren't going beyond here, you're not going to get the tendons on this side. That could sit right up against that bone, get a good angle, everything looks nice, does very low. If you get a wrist fracture, boom. You get a bone density study, start taking calcium in. Because you probably didn't take calcium, and you probably don't know your T-score. So, that's it right there. See that right there, that red arrow? It's pointing to this break.
Oh, yeah.
Nothing can replace that break, except for Forteo. But you don't want to take Forteo. But nothing, you can't put that bone back. It won't jump back and form another bridge. Everybody's happy. There's no more holding hands. Once you get to that level, that's it. You don't want to get to that level. You look at that bone, that's pretty thin bone. That person you may see somewhere, okay? So in summary, osteoporosis is preventable. Please know your T-score. Osteoporotic fracture can't be reversed, as we just showed. Nobody likes post-max. I do, but probably is probably the drug you want to take.